This is Sue, and in this screencast I'm going to discuss complications of IVs and the importance of frequent assessment of IV sites. It's important that we recognize signs and symptoms of some of the most common complications, things that we can do to prevent them or to minimize the risk, and actions that we can take when we do recognize that there's a complication. So first of all, let's look at the most common peripheral IV sites, and we will look at them in more detail in the unit on venipuncture and starting IVs. But just to give you an idea of the different areas where we will see IVs inserted. The arms and the hands are the most common locations in adults. We avoid the legs unless absolutely necessary because of the risk of phlebitis. Also, it's common practice to start looking at sites that are most distal in the arms. If there is a complication and we have to remove the IV, we cannot move further down the vein. We can only move further up the vein, more proximal. So if we anticipate that an IV is going to be in for more than a few days, we want to start as distally as we can so that we have vein to move up on. One of the problems is the more distal that we go, the smaller the veins are. And in general, smaller veins can have more complications than larger veins. So there's a lot of different things that we need to take into account. So if you look at the hand, the dorsal veins on the hand are actually very good sites to start IVs. And then in the forearm, we use the cephalic vein, the medial vein, and the basilic vein, which are all good, relatively large veins to run IVs in. And there's also central lines, which we won't be discussing in this screencast, but we will talk about them in another one. So for this one, we're mostly talking about peripheral sites. So first of all, how do we take care of the IV site? Well, we want to secure it so that the cannula doesn't move around a lot in the vein. Some of the most common complications are caused by the cannula moving in the vein and causing irritation. So we want to make sure it's secured well. And there's different devices to do that. In this picture, the one on the top, the dressing actually has a foam frame around it that helps secure it. The one on the bottom is a type of securing device that we see up in our neighborhood. It's called a Statlock, and we will show you those in the lab. We also want to keep the site clean and dry, and so we want to make sure that our dressing is occlusive, or that it's covering the entire site of the puncture that occurred. So the insertion site, we want it covered. We don't need to change the dressing or clean underneath it. Generally, we put the dressing on and leave it. However, if it does become wet underneath or starts leaking, we can take the old dressing off and put a new one on. A clear dressing is preferable, like in the picture on top, so that we can assess the site and see what it looks like. So very seldom do we put a gauze dressing over an IV unless it's very short term. So, complications of IV therapy. IV complications are some of the most common or frequent complications that occur, and the Joint Commission is very concerned about IV complications, and we need to take them seriously as well. Now, the thing about IV complications is that not all of them are preventable. The fact of the matter is that if a patient has an IV in, they have a foreign object, a foreign cannula inside their vein, and that can cause issues. But the secret is not that we can prevent it all the time, but that we recognize the complications quickly and minimize the damage that they can cause. So the Joint Commission tells us that we need to assess the site and document a minimum of every 2 hours. And we also need to educate the patient what to look for, because we're not at their bedside all the time. So we need to tell them if it looks red, if you notice any drainage from it, if it hurts, put on your call light so that I can come look at it. So some of the different complications. Well, the first one isn't really a patient complication, it's more of a mechanical issue, but I wanted to mention some of the things that can go wrong mechanically. So first of all, if the ordered flow rate isn't being maintained, what might be happening? Well, we want to look at the tubing first. The spike needs to be all the way in the bag of fluid or the bottle of fluid, or the holes won't be completely open on the IV tubing spike and it may not flow right. So make sure that it's inserted all the way. Make sure the clamps are all open, and look for any kinks or constrictions. And what might happen is if the patient rolls over on the IV tubing, or the tubing gets caught in the side rail, or gets caught in the pump clamp, that can cause issues. IV pumps are great, we like them, but they can be the problem actually. And we will be looking at pumps later. Pumps are nice because they can tell you the area of the problem, whether it's distal or proximal. It can tell us if there's air in the line or an occlusion in the line. But pumps are only as sensitive as we set them to be. And if we set them to be too sensitive to pick up problems, then the alarm is going off constantly, and we get what's called alarm fatigue, where we tend to not look at pump alarms as urgently as we would otherwise. So we'll look at pumps later. So one of the most common complications is infiltration. And infiltration is where the IV solution or IV medication, instead of flowing only into the vein, it flows into the surrounding tissue as well. And that can cause a lot of problems. Some of the different things that can cause infiltration, well, patients who have fragile veins are at greater risk. So that would be the elderly or people who have been on long-term steroids. The veins may be fragile and rupture. Also, over time, the vein wall where the needle was inserted decreases in elasticity, so the insertion site where the cannula is going into the vein dilates, and even though the cannula may be in the vein, it leaks around it. If an IV is in too long, it sets up an inflammatory process just because there's a foreign object there, and the spaces between the cells of the vein wall increase and fluid leaks out. So the cannula may be inside the vein totally, but fluid is leaking between the cells. In addition, the catheter can become dislodged from the vein, and that's one of the reasons we want to secure it very well so that it doesn't. The needle may go all the way through the vein when the IV is being started, and that's the picture on the top here in this slide shows the cannula going all the way through the vein. Usually, if the cannula went all the way through the vein, we see that at the time the IV is being started. We see hematoma forming really quickly, and we pull the IV out. But what sometimes happens is it doesn't go all the way through immediately, but it nicks the vein, and that area is weak and becomes weaker, and as fluid goes in, it might rupture and the cannula go through the wall. The picture on the bottom is an arm where infiltration of IV fluid has occurred, and you can see how swollen it looks. And we'll talk about what to look for here. So, signs and symptoms of infiltration. Well, the area gets swollen and the skin becomes very tight looking, as you can see in these two pictures. It's not edema, it's the IV fluid that's in the tissue, and so you may see swelling. Oftentimes the first symptom that the patient will have is that it hurts. They'll complain that their IV hurts, and we go in and look at it and their arm looks swollen. If we touch their skin, it's cool to the touch because the IV fluid that's under the skin or in the tissue is cooler than body temperature. The area looks blanched instead of reddened, and that's because of the pressure of the fluid against all the little arterioles and vessels in the hand or in the skin. Because of the pressure against them, it blanches. And we may see leaking around the insertion site because of the excess fluid. One of the things with infiltration, if the patient has been sitting or laying in one position and you go in and they're reporting that it hurts and you look at it and it looks fine, make sure and pick their hand up or pick the arm up, because sometimes the fluid goes to a dependent area and you may not see it unless you pick the arm up. So make sure and look carefully. So what do we do if we have an infiltration? Well, that site can't be salvaged, so we need to discontinue the IV and start a new one in another vein away from that site. And then we want to put either cool compresses or warm compresses on the site, and that depends on what type of fluid was infiltrated. And if we have an IV team, we can call them and they will let us know whether we want cool or warm compresses. Otherwise, we may have a protocol for the different types of fluid. If it's a medication, we can call pharmacy and ask them as well. And we want to document the site and do follow-up assessments. And usually there is a policy for how we do follow-up and what we document. Sometimes we may be measuring the area that's swollen. We may be documenting how far up the arm the swelling is. But look for that procedure so that you know how it needs to be documented. And infiltration is something that can happen simply because the patient has an IV in. Like I said, it's a foreign body, and the area around the insertion can dilate, the insertion into the vein can dilate, or the cells can get irritated and it can leak between the cells. So what we want to do is decrease the risk as much as we can. So some of the things that we can do is things that will decrease the movement of the cannula irritating the inside of the vein. So we want to avoid putting the IV in areas of flexion or movement if possible, so stay away from the wrist or the antecubital. We also want to choose the smallest cannula possible for the purpose that we're using it for. The smaller it is, the less it will rub against the inside of the vein. We want to make sure when we are inserting the IV that we're doing it correctly with the bevel of the needle up, so there's less chance of the vein getting nicked. And I'll show you that when we do our unit on IV starts. Also, don't count on the pump letting you know that there's an infiltration. It can pick it up. It may beep and tell you that there's an occlusion, but again, it depends on how sensitive we set the pump to be, and often it doesn't catch it until it's too late. So it's important that we are able to see this infiltration within 2 hours so that we can catch it. It can cause tissue damage even if it's an isotonic solution like normal saline, because it's putting pressure against the tissue. and can cause tissue damage. Another type of infiltration is where the fluid that is infiltrating is something that is that causes tissue damage and necrosis of the tissue. And we call that kind of fluid a vesicant, so a fluid that causes tissue damage. And that's extravasation, so that it's simply an infiltration of a vesicant. And when this happens, even a small infiltration can cause serious damage. Can cause blistering, necrosis, as you can see in this picture, and sometimes the damage is continuous for several days before it even stops. The types of fluids that cause extravasation are, for instance, anti-neoplastics or chemotherapy. IV contrast is very caustic. Potassium, so if your patient has a solution with potassium in it, or high electrolyte solutions. Also, many types of antibiotics are also very irritating. And often there will be a policy, or well, in the procedures and policies, there will be a document discussing some of the IV solutions or medications that are especially damaging to the tissue. So if we have an infiltration of a vesicant, same as with a regular infiltration, we stop the fluids but leave the cannula in place. So don't take the IV out, leave it in. And the reason why is sometimes there's an antidote that we can inject through the cannula into the tissue that helps. So discontinue the fluid but keep it in place. Call the physician and the pharmacy, and the pharmacy will tell us if there is an antidote that we can use. The physician has to order it though. And often we'll use ice because we want vasoconstriction to keep the fluid from causing further tissue damage. We'll elevate the limb, and often the patient will get steroids as well, but the damage can be significant. Sometimes if the patient's getting a solution that's very irritating, the physician may choose to start a central line because that is an IV that goes into a much larger vein, and the solution that's irritating gets diluted quicker and less chance of damage. If you have an irritating fluid, you want to avoid the hand and wrist, which is exactly what didn't happen in this picture. And the reason why is there's a much greater potential for nerve damage and causing a loss in functioning of the hand. So this would be a situation where instead of starting the IV more distally, we would want to start it more proximal to the heart, where the vessels are larger and there's more hemodilution. Here's another picture of an extravasation, and you can see where whatever the solution was, it infiltrated and went right up the vein and is causing tremendous damage. Phlebitis is also a very common IV complication, probably the most common one. And this is where the wall of the vein becomes inflamed and eventually may become infected. But phlebitis is just the inflammation, and again, it's caused because the patient has a foreign body in their vein and they are having a foreign solution being infused. Different types of phlebitis are mechanical, chemical, and bacterial. So a mechanical phlebitis is caused by the cannula rubbing up against the vein wall. And so again, making sure that it's secured very well will help diminish this. Also using the smallest cannula possible in the largest vein, given the situation. A chemical phlebitis is where an irritating medication or electrolyte solution causes irritation to the vein wall. Also, hypotonic solutions are have a greater risk. Hypotonic and hypertonic solutions have a greater risk of causing phlebitis than isotonic. With hypotonic solutions, the cells in the vein wall swell and could break, and with hypertonic solutions, the cells in the vein wall shrink and crack. So again, we want to look at the solution that the patient is getting. A bacterial phlebitis is caused by an infection, is caused by contamination of the site, and that is avoidable. There's no reason that should happen. When it does, the patient will have a sudden increase in their temperature, purulent drainage from the site, and that has to be, the physician needs to be informed about that. And you can see in this picture, there's phlebitis there at the site of the insertion and actually moving up the vein a little bit. And here's another couple of pictures of phlebitis. So signs and symptoms are often the first one is pain. So the patient puts on the call light and says that hurts. Or you go in and you start a solution or give an IV push medication and they say that hurts. The area feels warm to the touch because of the inflammation. It looks reddened and it may be swollen like the picture on top. Sometimes if it works its way up the vein, like the picture on the bottom there, you can actually feel the vein like a hard cord where it's become inflamed. You can actually feel it. So what do we do if we see phlebitis? Well, that's a site that can't be salvaged, so we discontinue the IV, take it out. For phlebitis, we use warm compresses, and this needs to be reported to the physician because it's a pathologic condition. With infiltration, if it's not the infiltration of a vesicant, if it's an infiltration of a non-irritating solution, we don't need to report it to the physician. But with phlebitis, we do. The other thing is we want to make sure and educate the patient so that they know what to look for. Phlebitis can actually occur up to 4 days after an IV's been discontinued, and often when we're discontinuing the IV is when the patient is going home. So we want to tell them to keep an eye on the IV site for the next several days, and if there's any redness or pain or tenderness, they should call their physician. So we want to decrease the risk as much as possible. Again, making sure that the cannula or that the IV is taped down well so the cannula doesn't move inside the vein and cause a mechanical phlebitis. If we're using an irritating solution, we would prefer to start the IV higher up on the arm or possibly a central line. Just keep an eye on it carefully so that if it does start becoming pink or warm or tender, we can discontinue the IV and restart it somewhere else. Sepsis, or CRBSI, which is catheter-related bloodstream infection. This is a systemic infection, very dangerous. And sepsis is something that is 100% avoidable. If a patient gets a bloodstream infection from an IV, it's something that somebody did wrong along the way, either when the IV was started, when tubing was changed, or tubing was connected to the IV tubing like an IV piggyback, aseptic technique wasn't used, or the dressing came up, it wasn't occlusive and didn't get changed. All those things can cause an infection, but they're all avoidable. They say that the major source of infection, once the cath is inserted, after that point in time, is the hub of the catheter tubing, so the rubber hubs or the Y sites. And so we have to be very careful each time we access those Y sites because we're risking introducing organisms. So scrubbing the hub is crucial. Scrubbing the hub for at least 10 to 15 seconds with good friction, and keeping the ends of the tubing sterile if we disconnect them. So signs and symptoms of sepsis, well, the area would be red, swelling, tenderness, and possibly drainage. The patient will become sick very quickly with fever, just malaise, so they're tired, they're weak, and eventually they can have respiratory collapse. Sepsis is very dangerous, so we want to be very careful with aseptic technique and scrubbing the hub. Whoops, what happened there? Okay, so here's, again, just some pictures showing the nurse using hand gel and really scrubbing the hub, scrubbing the threads of the hub and the top of the hub, and really good aseptic technique. Another complication that we see is hematomas. And hematomas are where there's blood that leaks into the tissue at the puncture site. It generally occurs either at the time that the IV is inserted or when the IV is discontinued. So when it's being inserted, the needle may nick or go through, puncture the vein. And when that happens, you can see the picture on top there. That was a hematoma that occurred when IV was being started. You usually see it swelling and having that purple-blue color pretty quickly, and so you know to remove the IV and put pressure on it. When it's discontinued, if adequate pressure isn't put at the site, you can also get a hematoma, and that's what looks like happened in the arm on the bottom there. So signs and symptoms are rapid swelling, ecchymosis, and it can be very painful. So if we see that happening, if it's happening when we're starting the IV, we discontinue it, put pressure on the site, and cold compresses to help prevent the leakage of the blood. And it's important to know which patients are at greatest risk. So patients that have more fragile veins, like the elderly, and patients on steroids, patients who are on anticoagulants, and also diabetics and patients with renal failure also are at greater risk of fragile veins. So we want to watch them close. Another complication is an air embolism, also very dangerous. We don't see them as often in peripheral lines. They are much more common in with central lines, but they're caused by air being introduced into the vein, and if the air embolism reaches the lungs, reaches the heart and then the lungs, it can cause big problems. So often, if the air enters through a peripheral site, it breaks up into smaller bubbles before it reaches the heart. And that's why sometimes it doesn't cause as great a problem as if the air is going into a central line, which when we talk about central lines, you'll see that the cannula ends in the superior vena cava right next to the heart, so much more dangerous. However, case studies have shown air embolisms, even with small amounts of air being introduced into peripheral lines. So have to be careful about that. So signs and symptoms of an air embolism are the patient becomes anxious, short of breath, they can become pale, they have shock symptoms, tachycardia, hypotension, may become confused and may go into cardiac arrest. In theory, if a patient has an embolism, we want to put the patient on their left side in a Trendelenburg or head down position, the idea being that the air embolism will go into the peak of the ventricle. I can't think of the word I want to say, the apex of the right ventricle, and keep it away from the lungs. But it's difficult to put someone in a left side Trendelenburg position if they're thrashing and anxious because they're not getting any air. And then, of course, put oxygen on them as well. So prevention of this is to not introduce air into the IV. So make sure that the tubing is primed, that all the air is out of the tubing, that if we are injecting anything into the IV, like with an IV push medication or a flush, that we don't have any air in the syringe. Okay, and that's prevention. So, since for most of these complications, nursing doesn't cause the complications. The IV causes the complications. What we want to do is to recognize it as quickly as possible, and that's why we assess the site every minimum of 2 hours or per protocol at your facility. If I had a patient that was getting an IV vesicant through a peripheral IV, I would want to be watching it more than every 2 hours. I'd want to keep an eye on it more frequently and make sure the patient knows to let me know if they feel anything uncomfortable at the site. So what we document is the flow rate and fluid type. So the patient is receiving normal saline at 150 mils an hour, for instance. We want to look, is the dressing intact or occlusive, which basically means the same thing. It means it's covering the puncture site. So dressing intact, dressing occlusive, same thing. And the 3 cardinal symptoms, signs and symptoms that we're looking for are erythema or redness, swelling, and pain. So we want, with our documentation, we want to show if there was the presence or the absence of those 3 things. And here is an example of what that documentation might look like. So D5-LR at 125 mils an hour, IV site without redness or swelling, denies pain, dressing dry and intact, or you can say dressing occlusive. Yay! Hopefully, if there has been a complication, you've caught it early before tissue damage occurs. Remember, you can't always prevent the complications, but you can catch them before they cause a lot of damage.